appreciate the opportunity to talk to this group. What I'm going to try to do is focus my talk on some work that we did as part of the Society for Healthcare Epidemiology, where we did a review of what is the clinical utility value of non-localizing signs and symptoms for ascertaining the presence of infection. And so this talk is going to be heavily focused on long-term care because this is where this issue is most pertinent. So I have no disclosures. What I hope to do is kind of just do a very quick review. You've been getting a lot of talks that are kind of emphasizing what are the consequences of overuse, misuse of antibiotics, so I won't spend a lot of time there. I do want to spend a little bit of time just highlighting what I feel are kind of the pertinent factors that are contributing to challenges with antibiotic prescribing in long-term care specifically, which is a very different clinical context than what we encounter in the hospitals or even in the clinic. But many of the kind of psychological behavioral issues that Dr. Linder and others kind of alluded to, I think are germane here. They just go through many more layers of individuals communicating, miscommunicating, and obviously there's a lot more surrogate decision making which creates challenges. And then I'll spend most of my time talking about the work that was published earlier this year in the Infection Control Hospital Epidemiology. And then I will finish up with just a plug for one of our toolkits that we develop in the state. It's obviously not the only one that's out there, and I'll try to allude to other resources for people's interest. Okay, so we all know that antibiotic overuse is a big problem in nursing homes. If you spend at least 6 months in a facility, about 70% of those individuals will get at least one course of antibiotics. We also know that there's a subpopulation of about 20% of residents who are hyperutilizers, getting 4, 5, 6 antibiotic treatment courses during a 6 or 12-month window. We also know that much of this prescribing is being driven by suspicion or kind of stated suspicion of urinary tract infection. And we know that many of those treatments are unnecessary. However, even if you kind of hone in on the necessary treatments, we often are choosing unnecessarily broad therapy and continuing therapy for excessively long durations. And so one of the points that hopefully I will emphasize as we go through this talk is there's a lot of potential low-hanging fruit. Even if you don't move the needle on preventing initiation of an antibiotic, there's still a lot of opportunity to do some error recovery. And then obviously we worry about this because it has harms at both the individual, the facility, and the regional level. Again, many of the talks that have been already given today have kind of hammered this home. So I want to just spend a little bit of time talking about many of the factors that contribute to antibiotic misuse, overuse. So it's important to understand that this is actually a fairly complicated process. This is a flow map that we created through a number of qualitative studies in a number of nursing homes in Pennsylvania and Wisconsin. And what is very clear is that there's a lot of communication handoffs occurring in this process before you actually get to the antibiotic treatment decision. And as a result of that, there's a lot of opportunity for information decay. And often, you have multiple nurses involved in the process because of shift change. The providers are not easily accessible. And so it's almost like that game of telephone that we played as kids. As you get to the end of the last message, you end up with a completely different story than what was originally there. And one can imagine that is not conducive to great decision making. Two, kind of related to that is almost all of the decision making in some level depends on the nursing staff, which is very different than in the hospital or the clinic setting where you typically have a patient-provider interaction. There's not a lot of intermediaries, and so there's a lot of papers being published on the role of nursing staff in antibiotic stewardship. Most of it is being written from the perspective of hospital antibiotic stewardship programs, but I would argue that nursing homes, the nursing staff, are the fundamental key to antibiotic stewardship. And again, this is a hard message to get across because at the end of the day, it's the provider making the decision, but it is so important to understand that how the nurses do their assessment, how they communicate their findings, how they frame their findings to the provider has such a major influence on prescribing. The example that I give is if a nurse calls up Dr. Smith and says, Mrs. Jones seems off, do you want me to get a urine culture and start an antibiotic, versus Dr. Smith, Mrs. Jones is behaving a little bit out of hand today, not really wanting to eat, but she has no fever, her other vital signs are stable, she has no suprapubic tenderness, her urine frequency doesn't seem to be changed. I think that this could be just related to her underlying dementia. Do you mind if we just monitor her vital signs regularly and hold off on any culturing and testing? I think you would very quickly see a very different decision made by that provider. And so I spend a lot of time talking to nursing staff in nursing homes. We actually can extend our sphere of influence. Now, again, I won't deny that there are sociopathic providers out there who are going to do what they're going to do. But design your system for the non-sociopaths and try to get rid of the sociopaths when you can, is the way that I recommend it. And then the other thing that I already alluded to is, remember, this is not a single decision. So we spend a lot of time and effort on making sure we don't start that antibiotic when it's not necessary. But even if you kind of mistakenly start an antibiotic for whatever reason, there's a lot of opportunity to kind of circle back and correct that error. And that might be stopping an antibiotic in retrospect that seems unnecessary, narrowing down to a safer antibiotic choice, and using a shorter duration of therapy. And so what we need to do, not sure what happened there, is kind of routinize the antibiotic timeout in nursing homes. And right now, this is not happening. So again, this is, I think, another opportunity for nursing homes to look at. How do we kind of have a mandatory touch back in with the provider 2, 3, 4 days down the road and kind of reassess, should we have, in retrospect, was it appropriate to start this antibiotic? And if additional information became available, stop that antibiotic if it's not necessary. And then if you've got cultures that kind of suggest we can get by with nitrofurantoin and the patient's on no thinkacillin, maybe we can narrow it to that. And if the provider said, well, let's do 14 days and the patient is already improving rapidly and in retrospect it looks like a fairly simple infection, can we kind of shorten that duration of therapy to 7 days rather than giving 14 days? So I think there's a lot of opportunity there. But I think the biggest challenge, and this isn't going to go away, there's nothing that we can kind of design in our system to avoid the fact that this is an extraordinarily challenging population to do assessments on because of the high burden of cognitive impairment. And so it's this issue of what to do with resident change in condition, which may be related to infection. But there's a lot of other things that could be driving that change in condition. And again, this has been shown in study after study after study that it's the minor behavioral changes that usually trigger concern for UTI and lead to the urine culture and lead to the antibiotic. And what I'm here to tell you, as hopefully I'll show, is that what we really need to do is have a system that allows us to delay action when all we have are these kind of minor non-localizing symptoms, and be able to respond appropriately when we have kind of the warning signs. And I'm going to show you this in a few slides. But it's this problem that we have with behavior change or change in urine or patient just being more feisty today that kind of leads to a lot of antibiotic overuse. So when we look at that kind of feistiness or anorexia or other kind of non-specific behavioral change, it's important to understand that there are a lot of other things that can drive that in this resident population. So obviously medications, this resident population is on a lot of different psychoactive medications, and if they're having med changes, if they have a change in their renal function that leads to accumulation, or they get started on another medication that interacts with that medication. So it's really important to be looking at medications as a potential trigger. Dehydration, exceedingly common in this population. Uncontrolled pain, constipation, disruption to sleep patterns. All of these things are far more commonly associated with that behavioral change that often leads to clinical concern for UTI. And so we need to have a system in place that allows us to kind of recognize that this is the reality of taking care of this patient population. So we need to have systems in place that allow us to deal with this. So that was kind of our task with this document, and it actually got accepted for publication at the end of 2020, but didn't get published until the spring of this year. So it's been out there online, but didn't show up in publication until this year. So here's our timeline. I won't spend a long time talking about it, but it was a long process that went through kind of different turns, and this was originally designed as kind of the first of a two-part project where we were going to update the lobe criteria, and we are still planning to do that, but we had this little pandemic that kind of got in the way. So we haven't gotten around to that yet, but I want to make sure that we spend a lot of time talking about the specific elements. So this process was really centered around trying to answer two questions. One, how do we define the presence of a non-localizing sign and symptom? So if I say the resident has fever, what are the criteria that kind of establish that individual has fever? Is it a temperature of 99? Is it 100? Is it some change in baseline temperature? So that's the first part. The second part is, what is the relationship between that isolated non-localizing symptom, and what I'm very explicit to say, isolated is doing a lot of heavy lifting there. So if that's the only thing I have in this resident, is that sufficient evidence to trigger concern for infection or not? And that was kind of the question that we were trying to answer with this. And so we basically broke up into groups. We had two individuals from our group who did the deep dive into the literature, attempted to answer both of those questions, and then brought it back to the group for review and consensus. Once we had kind of established language for how we answered those questions for each of the non-localizing signs and symptoms that I'm going to review here in just a few slides, we brought it back to the group for anonymous voting to see whether there was agreement with that language, and if there was any discrepancies, then we kind of talked it out, and then Robin Jump, Dr. Rowe and myself did writing of the original draft, and then brought it back to the group for edits, and that's the final version that you should have available to you in ITCHE. So the intended use here, again, this is guidance, not a guideline, so hopefully CMS won't be incorporating this into any kind of regulatory guidance. We designed this with skilled nursing facilities in mind, but could be applied to the assisted living population or to cognitively impaired older adults who might be in the community setting. As I said, this was intended to serve as kind of the initial foundation for an update to the lobe minimum criteria, which are commonly used in research studies looking at antibiotic use appropriateness in nursing homes, and we're hoping to get that done in the next year. And then really at the end of the day, what we're trying to do is kind of lay a foundation for if we have one of these non-localizing signs and symptoms, is that by itself justification to kind of initiate an infection workup, culturing, empiric antibiotic therapy or not? And if the answer to that is no, we're trying to be very explicit about what you should do when you encounter those isolated non-localizing signs and symptoms. So first and foremost, we agree that this is a high-risk resident population or patient population. They get sick quick, they can go to the hospital, and so we certainly don't want to harm individuals by missing infections or kind of having an overly rigid approach that leads to under-testing, under-treatment in this population. Now, if you have kind of a high-risk non-localizing sign or symptom, then obviously we want to do a complete vital sign, do a good primary assessment where you're looking for where is the source of infection. One of the big problems that we encounter a lot in skilled nursing facilities is UTI gets blamed on a lot of things. And antibiotics for UTI are very different than antibiotics for pneumonia. And if you start treating people for UTI and undertreat their pneumonia, they're going to end up in the hospital with sepsis-related pneumonia. And so it's important that part of that assessment is focused on, well, where else could this individual have infection? And so that's usually focused on what I call the pus infections, pneumonia, UTI, skin, and soft tissue. And so you want to make sure that your nursing staff are directing their kind of history that they can obtain from these individuals and family members, as well as the physical exam to those big three infections. Again, not limiting yourself to those, but at a minimum, the initial nursing survey should be focused on those. Consider the possibility that there are non-infectious explanations. Again, medications, uncontrolled pain, disrupted sleep are very common. And then minimal laboratory, CBC with the differential is a very reasonable thing to do across the board, but targeting other diagnostic testing to what your nursing assessment physical exam led to. So if they have tachypnea, change in oxygenation, why are you getting a urine culture? Get your chest x-ray, and if possible, get a respiratory specimen, but that's often not feasible in this patient population. But do not get a urine culture because that's just going to distract from what the real problem is. And so we're big advocates for doing assessment-directed further testing. And with individuals who are simply presenting with kind of these non-specific, non-localizing signs and symptoms, again, I'm going to highlight those explicitly here in the next few slides, then really you do the same as far as vital signs and initial primary, and if that primary assessment doesn't identify localizing signs or symptoms that suggest infection. So again, if I did my primary assessment and the resident in front of me has cough, has hypoxemia that's new for them, then obviously I've flipped them over into a clinical concern for pneumonia. But if I go through that assessment and all I have is a change in behavior but nothing else, then what we would strongly advocate nursing homes try to operationalize is do active monitoring. And we use that language because family members will perceive this as quote unquote doing nothing, so you're just going to watch them. And the answer is, yeah, we're just going to watch them because over-treating these people can result in many more harms. Again, Dr. Linder's language about how to kind of reframe this is so useful, I think, in kind of adapting that to our interactions with family members. So in those situations, what does this mean? It means we're going to be doing vital signs every shift. We're going to be encouraging hydration, and we're going to have kind of criteria for recalling or recontacting the provider. And what we've done in our Wisconsin UTI Toolkit, which I think is a great idea, it's not something unique to our toolkit, it's been done in other toolkits, is we develop temporary order sets for active monitoring that get implemented in the nursing home. And this kind of reinforces the notion that this is an explicit action that the nursing home is taking to enhance the safety of the resident and family's loved ones, and really kind of helps operationalize things. And so here's kind of the framework that we laid out about 10 years ago now with myself and Paul Drinka, is kind of this sequential approach where you're trying to ask a few questions. So the first diamond here is we have some non-specific sign or symptom that triggers some elevated concern for UTI. And so the first question we're asking is, does this individual have localizing history or exam findings that kind of suggest that the urinary tract is potentially an area of concern? And if they don't have dysuria, if they don't have frequency, if they don't have suprapubic tenderness on exam, then you kind of go to your next question where you're asking, do they have localizing symptoms somewhere else? Because we don't want to miss that pneumonia. And if the answer to that is no, do they have any warning signs? And the warning signs we use here are fever, hemodynamic instability. And if the answer to that is no, you've kind of established that this is a low-risk change in condition, and this is where we would go to active monitoring, avoid urine testing, avoid empiric antibiotic therapy. And if your answer to those is yes at any point, then you're kind of out of that algorithm towards active monitoring. Okay, so what are signs and symptoms that we felt from our group were where there's evidence to support, they should kind of lead to additional testing and a stronger consideration for infection. Well, clearly fever is one of those non-localizing signs and symptoms. And again, we're utilizing thresholds that I think are pretty well accepted now in the literature, that a single temperature exceeding 100 in this population, or having repeated temperatures above 99, or more valuable, although harder to ascertain, is a 2.2 degree Fahrenheit in temperature above baseline, or a 1.1 degrees Celsius temperature elevation above baseline. But obviously that entails you knowing what this individual's baseline temperature is. And so that sometimes is difficult to operationalize. But again, another area that nursing homes could potentially establish through serial monitoring and saying this patient's temperature normally is somewhere around 96.4, and having that somewhere in the chart that allows it to be accessible information. And then when they get to be 98.8 or something like that, that would be concerning for that individual resident. So again, an area for nursing homes to think about, challenging to operationalize. Hypothermia is kind of the flip side. Again, it's important to remember that temperature regulation in this population is difficult. And so if there's significant drops in ambient temperature, that's often one of the most common reasons for hypothermia. So raise the temperature in the room, make sure that this is not real hypothermia, make sure that you're getting the temperature accurate, because that's another common reason for hypothermia. But if you have true hypothermia, that's a warning sign, and that's equivalent to having a fever from a clinical perspective. Hypotension. Again, this is a population where hypotension is very common. We have a lot of heart failure. These patients are on a lot of cardiac medications that lower blood pressure, and it's not unusual to have a resident whose systolic blood pressure is normally 95. And so we spent a lot of time talking about this. Because there are sepsis recognition guidelines out there. Minnesota has the 100, 100, 100. So if you have a temperature greater than 100, a heart rate greater than 100, and a blood pressure less than a 100, that patient could have sepsis. And the problem with those kind of across-the-board approaches is, I guarantee you there's probably about 10% of your resident population who have a systolic blood pressure at baseline that's below 100. And so you want to be careful with those. So we kind of use some weasel words in our approaches, saying 100 is fine for somebody whose baseline blood pressure is, systolic blood pressure is greater than 100. But if they're below 100 or close to 100, then you should probably set that threshold lower at 90. Or if they have a 40% drop in absolute terms below their baseline, that would be another term. Hyperglycemia was another area that we had some discussion about. The problem with this is it was impossible for us to kind of establish a threshold, because everybody's blood sugars are kind of unique to them, and kind of setting absolute thresholds of hyperglycemia was impossible. We couldn't find any literature to kind of support absolute thresholds. But in an individual where you have really good history of what their blood sugars are, and all of a sudden their blood sugars kind of take off and are more uncontrolled, that can often be an initial finding that's concerning for infection. Again, all of these things are with the caveat that by themselves doesn't trigger antibiotics or diagnostic testing. It just says it's very reasonable to move forward with additional evaluation and assessment for the possibility of infection. And then we were very explicit about saying delirium by itself should be a concern for infection. And I think there's plenty of evidence now to support that in the literature. The problem is that nobody really does formal assessments for delirium, or if they do, they don't do it as part of this, and they kind of conflate a subtle behavior change as being the equivalent of delirium. And that's the problem that we have here. So it's really important that we try to be more rigorous in our assessment of what a mental status change is. And if that's what's kind of triggering things, then part of the initial assessment by the nurse is to do the CAM methodology, which is kind of based on an acute change with fluctuating kind of parameters, inattention, disorganized thinking or altered level of consciousness. And if you have, those first two plus one of those second two, then you've met or you've established that this individual in front of you has delirium, and that has been well shown to be correlated with the presence of infection or something else seriously physiologically wrong with that individual, and would justify a workup and potentially empiric therapy. Now, the things that our investigation did not identify support for are a number of things, and I just kind of alluded to one of those. Behavior change not meeting criteria for delirium. So if that's all you have in the absence of fever or other localizing signs and symptoms, then the best thing to do in those situations is activate, active monitoring plan. And if something changes or worsens, then obviously you get on it right away. But this by itself should not trigger a workup or therapy for infection. Functional decline, again, another topic that we had a lot of ongoing conversation, because there was no question that there is an association between infection and functional decline. Where we had a lot of discussion about was this chicken or egg phenomenon. Is functional decline after the infection, or can you use functional decline as kind of a leading indicator of infection? And we couldn't find any literature that suggested that functional decline is a good leading indication of infection, meaning it's the first thing that you see in an infection versus somebody who gets a pneumonia and then has functional decline as a result of the pneumonia. So I want to be clear here, there is an association between infection and functional decline, but functional decline can't be used to trigger concern for infection, or at least there's no evidence to suggest that it can be useful for that purpose. And this is one area that we do differ with the modified McGeer criteria, because functional decline was incorporated explicitly into the surveillance definitions for nursing homes. And again, it may be perfectly fine for a surveillance perspective, but using it clinically to establish the presence of infection was more problematic to us, because surveillance is a process that we do retrospectively, not prospectively. And then finally, falls. Again, we can find a lot of literature that shows a higher rate of falls in people with infection, but similar to functional decline, is it a leading indicator of infection? Meaning, is that the first manifestation of infection or not? And again, we couldn't find any literature to support that kind of sequence of events. And we continue to see papers being written, off of MDS data and other nursing home data showing if your resident falls, you should be concerned about infection. And probably the most common scenario that we encounter is resident has fall, some injury, goes to the ED, they shotgun kind of a test, they get a urinalysis that's abnormal, and they come back on an antibiotic. And so that's a perfect example where routinizing the antibiotic timeout can be really helpful in kind of doing error recovery, because unless you have a really good established relationship with your ED, you're probably not going to change that practice a whole lot. But can you implement a process on your end where residents who go to the nursing home or go from the nursing home to the ED, when they come back on an antibiotic, do we have a process in place for reviewing, was that appropriate, or was this kind of one of those shotgunned, triggered antibiotic prescriptions in the ED? And then anorexia kind of falls into that same category as non-delirious behavior change. Again, no evidence that anorexia by itself is kind of a true indicator of infection. So we have tried to implement those into one of the toolkits that we've developed with stakeholders from our nursing homes in the state, stakeholders from public health, and this is freely available if you go to the URL link that's available here. Otherwise, you can Google Clinical Resource Center UTI Toolkit, and that'll take you to this. Again, there are other really good toolkits out there. Massachusetts has a nice one that's available. ARC, as Dr. Linder alluded to, also has some toolkits that are very useful. I think there are some resources even in this state. Is that true, Salman? I think so. Maybe I'm making that up. You also have kind of a UTI toolkit for Nebraska.
It's not a toolkit, but we have
Got it. Okay. So this toolkit has a lot of different resources. We made specific intent to focus resources at nursing staff, providers, and families. We've got a lot of educational resources that can be adapted to in-services for the nursing staff that kind of walk through this framework. Is this a high-risk change in condition, low-risk change in condition? If it's low risk, we've got kind of scripted language in there for nursing staff to utilize in their interactions with providers to kind of intimate that this is a low risk and kind of promoting active monitoring in those scenarios. And we've got example of a temporary care plan for active monitoring built into that. So take a look at it. There may be things that you can utilize there. Trying to implement the whole toolkit from soup to nuts, probably a lot of work, and with everything that's going on with COVID and staffing issues, probably not something you're looking forward to doing right now, but there may be some things there that you can borrow and start integrating in small pieces as you kind of build towards a more robust utilization implementation of this toolkit. The other thing that's kind of built into this for the providers is kind of this explicit expectation that if you start an antibiotic, you are obligated as a professional to circle back and say, was this the right decision? Did I choose the right antibiotic? Can I stop the antibiotic? Do I need to change the antibiotic? And can I shorten the duration of the antibiotic? And again, getting your medical director on board to kind of help establish that kind of behavioral or cultural norm, I think can be very helpful. And we just completed a study where the primary research question was focused on different types of implementation, so I won't bore you with the details of that. So we were interested in, does standard implementation versus an enhanced implementation augmented with coaching and peer comparisons lead to better implementation and sustainment of the toolkit. Unfortunately, COVID kind of hit right in the middle of that study. We got some interesting findings out of that we presented at ID Week last year, and we're in the process of writing those up. But one thing that happened, so across the 30 facilities that we implemented the Wisconsin UTI toolkit in, we saw a significant drop in urine cultures, significant drop in antibiotic starts, and an even greater drop in fluoroquinolone starts and duration of antibiotic therapy. So we feel very comfortable in saying that facilities that implemented this actually saw demonstrable improvements in these kind of outcomes, which are very important. I'm going to stop there. I hope I kind of hit my time target and open it up to questions.
Thank you, Dr. Crnich. A great presentation. Quick question on that toolkit. How did you go about educating the nursing staff on those toolkits? How much resources did it require? What kind of training?
So kind of coming back to the kind of research questions, as I said, the question we were interested in was kind of an implementation issue. And so everybody got a half-day kickoff where we kind of walked through some of the things that we're talking about here right now, some of the key elements of the toolkit, how to use some of the scenarios for in-services with nursing staff. That was a big component of it, is kind of walking through how to kind of teach your nursing staff to do an assessment and how to communicate this is a low-risk change in condition versus a high-risk change in condition. So that was a half-day session. Now, all of those are recorded, available on the toolkit. So I don't think it's absolutely necessary that a state or a region kind of spend a half day, because all of that is kind of built into the cake there. And then for the enhanced implementation, we had another half day on top of that, so it was a full day orientation. There was a coach call that occurred on a monthly basis, actually every 2 weeks when we were first getting up and running for the first 2 months, and then it kind of dropped back to monthly. And then we had quarterly kind of group learning sessions that happened over the 12-month implementation. So if you were in the enhanced arm, you're probably looking at a full day, and then at least an hour a month with a coach, and then another hour every 3 months where you were kind of sharing experiences, what worked, what didn't work, or were having these challenges. So relatively low touch, but for a nursing home, still fairly high intense. I mean, it's high cost from that perspective. But again, we've built the toolkit up into kind of manageable pieces. So under each, we kind of broke it around, how to prevent UTI, and then we said when to test, when to treat, how to treat. And so we kind of broke it up into those pieces. And even under each of those modules, there's kind of, it's broken up into bite-sized pieces so people don't have to spend a whole hour at a time kind of going through content. People can usually get through, the content is structured in a way that allows somebody to sit down for 20 minutes and kind of consume what's there in a reasonable, manageable time-sized piece, because we know people's time and energy is very limited in this setting. No problem. Other questions?
Hi, I actually had a question about what kinds of conversations you had about speaking with families.
Yep.
And the challenge that the nurses face in trying to explain to families who think that their mother always has a UTI when they're confused, et cetera.
Yeah,
Can you speak to that?
I can, and it was kind of addressed a little bit earlier by our previous speakers. It's a huge issue. And my advice is that facilities try to get proactive in messaging this out to family members. And I'm not sure how useful or winnable these situations are in the moment that a resident's having a change in condition. It's a little bit like having a goals of care conversation and somebody who's coding in front of you. You need to be having those goals of care conversation before the cardiac arrest occurs. And that's the same thing here, is I think at entry into the facility is a really good time, particularly if your intake is showing this is a person who's been quote unquote recurrent UTIs, and their med list says that in the last 6 months they've had 5 courses of antibiotics. That's somebody where you want to kind of have a proactive conversation with them saying, okay, we're not sure how UTI was diagnosed in the past. Here are the downsides. And so some of the language that Dr. Linder was alluding to, I think, could be very useful. Now, in our toolkit, and ARC, Agency for Healthcare Research and Quality, has a lot of family education materials built into it, and I think those are very useful. I think attending family council meetings, resident council meetings are really good, where up front, before you have a change in condition, you're having those conversations. Is it going to work for everybody? No. But I think it is going to move the needle on a substantial number of residents, and then working with providers and/or the medical director for that population that are kind of the problem child, I think trying to come up with a proactive game plan for dealing with them is what I would recommend. Because if you try to have these conversations while the resident is experiencing a change in condition, anxiety levels are high, it's just going to lead to conflict that's unnecessary. And so I would say bite the bullet with that episode and then try to readdress it for, can we prevent this from happening with the next episode? That would be my recommendation for approaching that.